Today we're at the histopathology department at Milton Keynes Hospital, and I want to introduce you to Peter Mooney, who's the laboratory manager here. This is a busy histopathology department, and Peter's going to introduce us to the kind of work that goes on here.
Yes, welcome David. Welcome to a relatively busy histology department. We do about 400 to 500 specimens a week. We get specimens from GP surgeries, we get them from outpatient clinics, and of course from inpatients in theatres. That's the main source. We do get the occasional autopsy specimen, but that's few and far between. The majority are from clinics within the hospital. It could be dermatology, endoscopy.
Okay, and from the time that you receive a specimen, how long does it take till it actually hits the desk of a pathologist?
Yeah, this is a problem we have with clinicians. They take a blood sample, press a button, out comes a result. With histology, it's quite different. It depends very much on the size of the specimen. If it's a very small biopsy, and it arrives midday, we can have a result maybe tomorrow. Mm-hmm. If it's a much larger specimen, like a breast or a colon specimen, it can take 1 or 2 days to get a result. So it's very much dependent on the type of specimen and the size of the specimen.
So can you take us through the
process
process as it goes here?
Let's go, let's follow the process.
So this is where we start?
Starting where the book in. Yeah.
Okay, good.
Yeah.
So this is where you receive your specimens here.
It is.
And then what do you do with them?
Well, this is our specimen reception area. So this is, we get all the specimens from theatres and clinics, as I talked earlier. The first thing we have to do is check that the request card has got exactly the same details as the specimen pod. It's vital. If there's any discrepancy, it goes back to where it came from till it's done properly. The specimens all arrive in various size pots. You can see here very small ones. There's a tiny little biopsy in the bottom of that one.
Oh yes.
We have much larger pots going up to 5 litres, depending what the type of specimen is. They are obviously from theatres, specimens, larger specimens. These tend to be from GPs or clinics.
Okay, so I mean, what kind of specimen was in that one?
That one there is an esophageal biopsy.
Okay.
You can see how small it is.
Yes, it's tiny.
Yeah.
And the large ones, what kind of specimens are they?
In this one, there's uterus and fallopian tubes. They're both uterus and fallopian tubes. But we see breast tissue, colon tissue, kidney. You name an organ, we'll get it, and we'll have a look at it. The thing to say, of course, is these pots contain formaldehyde. Mm-hmm. Formaldehyde's a bit toxic. It's not very nice. So whenever we open the pots, we always do it on downdraft tables, which I'll show you later. Yeah. And we monitor the levels in the lab on a regular basis. So what happens then, if we're quite happy with this specimen, it's booked in on the computer system. This is a pan-pathology computer system, which the chemists have, the hematologists have, transfusion. And Rocio is booking the specimen in now, and it'll be given a unique lab number. The name then stops. We don't relate to the name, we relate to the lab number. Okay. So it'll be 16H, whatever the number is.
And does this go to a central database then?
It does. All the patient's history is on there if the patient's been here before. It's all held centrally, yeah.
Okay.
Yeah. When it's booked in, we get some labels coming out. We get one for the pot, one for the card, and at the same time, there's a cassette produced, which are these funny coloured things on the top of here.
Is there any difference between the colours on these?
Yes, there is. The cassette, which is going to have the tissue in it eventually, has the lab number on, which is there, and what's in the tissue, what's in the pot. The colours denote urgency. If you come in, if your GP has referred you to the hospital because they're worried about a condition you have and that it could be serious, we treat those as urgent. So a prostate biopsy, a breast biopsy, anything like that somebody thinks we'll treat very urgently.
So you'd be looking for diagnosis of cancer in this case?
Yeah. So the red cassettes denote urgency. There is a reason why these large specimens are urgent. The clinicians suspect something. Okay. These ones are, this is a skin lesion. The patient may well have had it for 20 years and has decided to go to a GP.
Less urgent.
Less urgent, yes.
Okay.
Yeah.
So you've booked your specimens in, and now what are you going to do with them?
Well, this is the first real step in the process, David. What we do is we examine the specimens macroscopically. The specimens are arriving throughout the day, and we have biomedical scientists look at specimens as well as pathologists, and we make a macroscopic description and we dictate it. The person will be wearing headphones, and we have secretarial staff upstairs typing as they speak, more or less. The tissue is put in the cassettes. Now, it depends again on the size of the tissue. The one we showed earlier, which was a tiny little, about 1 millimetre, 2 millimetre sized esophageal biopsy, that would be put in the cassette with a lid put on it.
As is.
As is.
Yes.
The much larger specimens, of course, we couldn't possibly sample it all. So if it's got a tumour, we'd sample the tumour, the resection margins, and that's very much an experiential thing.
So it's really important to get exactly the right bit of the tissue to look at.
Absolutely, yes. Sampling tumours, limits of resection, which is very much an experienced pathologist would do that.
So it's the pathologist that will be looking at the initial cutting of the
larger
tissue.
specimens, absolutely.
Okay.
More and more labs are trying to train biomedical scientists to do this, but it's a lot of training involved.
Very skilled, obviously.
Very skilled, yes. So it's very important that the block of sample of tissue that goes into the cassette is what's going to be seen down the microscope later on.
Okay.
You can always go back to the specimen, of course, and take more.
Okay.
But of course that would slow the process up.
Of course.
It's better to get it right first time.
Okay, so can we go and have a look at the next stage now?
Yes, of course. Yeah,
Great,
do that now.
let's go.
Yeah.
So you've got your samples now on the cassettes. What happens to them here?
Well, this is the tissue processing stage. What we're trying to do is to try to get a very thin section of tissue onto a microscope slide so we can look down a microscope. To do that, we need a nice firm piece of tissue. We're replacing all the water in the tissue is about 80% water, with wax. A bit like candle wax, it's called fibre wax, slightly specialised wax. Quite a slow process, usually overnight. Most of the specimens go overnight. So, as I alluded to earlier with haematology, chemistry, they can get results very quickly. Histology is much slower because the tissue cassettes are going in here, and overnight these reagents, IMS, industrial methylated spirit, and xylene, and finally wax, will visit the reaction chamber. And over that length of time, by 8 o'clock tomorrow morning, all the water will have been removed from the tissue and it'll be replaced by wax.
So obviously the whole of that process is effectively automated by this machine.
It
you
is,
just have
yes.
to put the material in.
Put the material in, press the button.
And then it comes out first thing the next morning.
The following morning at 8 o'clock or whenever,
Yeah.
you look in there, you think nothing is different, only the tissue, instead of sitting in formalin, is sitting in wax.
Okay, and then where do you take the tissue?
From there, we take it for embedding.
Okay, and that's back in the main lab.
That's back in the main lab.
Okay, let's go and have a look at that then. So this next process is embedding here. What happens at this station?
Well, following the processing, which has happened overnight, the following morning, all the cassettes are taken out of the machine and embedded in moulds. So there are various sized moulds, and what Liz is doing at the moment is she's taking a mould, put the tissue in the mould. In here, there's molten wax, and this is a dispenser which dispenses wax. This stage is very important. However the tissue has been cut, if it's a skin biopsy and it's a transverse section, it must be orientated correctly, because the way the tissue is orientated in that mould will dictate what it looks like on the microscope slide.
And that determines whether the pathologist can see what they're really interested in seeing at that stage.
Yes, and you have to get it right first time. If it's a piece of skin and it's been poorly orientated and it's been cut, you could try to reorientate it in the wax, but chances are that's been cut away.
So it's almost back to square one at that stage, yes, if it's not right.
Yes,
here.
but we're always aware that this is a one-only sample. It's not like a blood sample.
Okay.
We can't go back to the patient for a blood sample. This is a once-only lesion, possibly. So this stage is very important. So this is a case in point. Liz has been very careful to orientate the sample the correct way around. It's a piece of skin with the epidermis and the dermis. So when you look at the microscope slide, it's the right way around. So this is topped up with wax, And this is a cold plate.
Okay.
To solidify the wax.
Okay, so these that was a liquid one, and this is now a solid one.
So this one was done a little while ago, and may come out the mould. Looking like that.
Okay.
Okay, so we've got the details along there, and we've got the tissue embedded in there.
And that will go on now for sectioning.
It will do, yes, which is the next stage.
Okay, let's go and take a look at that then. So you've got the specimens now in their wax blocks, and they're going to be sectioned on the microtome.
That's
here.
right. A microtome is where the sections are cut from. Every time Vicky turns the handle, it advances the cassette by 0.003 of a millimetre. That's about a cell thick. So it's very important that the sections are thin. You don't want to be looking down a microscope and seeing a thick section with cells piled on top of each other. It's got to be nice and thin. So again, quite labour intensive, like the embedding stage, and quite skilled. Often people refer to histology more of an art than a science, because it takes practice and experience. What Vicky's done is she's taken a ribbon of tissue, floated onto some warm distilled water, picked it up with a microscope slide.
How many sections would be taken from a single specimen normally?
If it's a large block, we'll just take the one section. If it's a smaller piece of tissue, like the esophageal biopsy we looked at earlier, you'd take 3 sections at different levels through the tissue. Because it's small, you can't judge by eye that you've actually caught everything. There may be something lurking further down, so we do 3 levels.
Again, it's to hit exactly the right place in the tissue so that you don't miss a lesion or something really important.
Yeah.
Okay.
Yeah.
So we've now got these sections on the slides.
Yeah.
What happens to them now?
When the water's drained from them, they'll be put in an oven, and the wax will be melted onto the slide to make sure the tissue sticks to the slide.
Yes.
And that's the end of this process, and then it'll be staining after that.
Okay, can we go and look at some staining machines?
Yeah.
Okay, great, let's go.
So, the next stage, we've got the sections on the glass slide, but of course we can't see anything down the microscope.
Yep.
So now we have to stain the tissue. Now this is a multi-stainer. We'll do various stains on here, but the one we're interested in is called a hematoxin eosin, or H&E.
Yes.
People refer to it. It's a purple stain and a pink stain, and the purple stain stains the cell nucleus, purple, and the cytoplasm stains pink. The machine's pre-programmed, so it knows what to do. We have various coloured clips, so we put a red clip on it, the machine knows to stain it with H&E stains.
Okay.
We have other staining techniques.
Oh, it's a coding system.
It's a coding system, so it recognises it. So basically, you pop it in the machine, close the drawer. An arm will come across, and what this machine is doing the reverse of the processing machine. It's taking all the wax off the tissue, and it's replacing it with water, and it's putting the stains in the relevant places. So it goes into xylene, then alcohol, then water, the tissue is stained, and then it's cover slipped.
So there are a lot of different things in there. Does this machine do things other than hematoxin and eosin?
There's a stain called periodic acid Schiff, and we use that. We use it for staining immunosections, immunohistochemistry sections. So we can set it up to how we want, when we want.
Is all the staining done automatically now, or do you do any hand staining?
No, we do hand staining as well. There's this is the automated section, but we do on this bench, we do special stains. So you can see all these bottles of tinctorial stains.
Yes.
We can stain for bacteria, for acid-fast bacilli, amyloid, fat, lots of different elements within the tissue.
Those would be much less commonly done. It's normally H&E, isn't it?
H&E, yes, much less common. If a pathologist looks down the microscope and they see something that might be tuberculous, they would ask for a Zeal-Nielsen stain.
So, how long does this machine take to do the H&E staining?
It takes about 30 minutes or so to do an H&E. As it goes, it ends up in xylene, and then it has a cover slip put on. Actually, there's one happening at the moment where the slide is being raised up, it's had some mounted, and a thin cover slip put on it, and this is done automatically. It's very important at this stage not to get any air bubbles under the cover slip, because down a microscope the air bubbles look huge.
Yes.
So this machine achieves that without air bubbles. So,
and it's assembling them on a rack here,
yeah,
ready to go to microscopy.
That's right.
Okay, Peter, so you've got your stained sections now and you need to marry them up to the original blocks from which they came.
That's right. This is a very important step. We have to ensure that the tissue on this glass slide marries up exactly with the tissue in the block. So we check the numbers, we do a visual check at this stage that it's correct. Throughout the process in the lab, of course, the card has been annotated with initials of all the members of staff to ensure that the tissue is correct, the names are correct, the numbers are correct.
So every single stage you've got checks going through to
Yes.
make sure that you've got absolutely the right tissue and the right sections.
Absolutely vital, because if we make an error, the worst error will be to send a report out on a John Smith when it really belongs to a Jane Smith.
A wrong diagnosis, in other words.
Absolutely.
Okay.
So we have as many checks as possible built into the system to ensure that doesn't happen.
Okay, so this is very rigorous quality control right
Absolutely.
the way through.
Yes, yes. Both microscopically, like we're doing here, and later microscopically.
So presumably the first thing is that you check that you've got the right tissue and everything else, and you do that on a microscope in the lab here.
That's right.
Before it goes to
we're
the
doing a visual
pathologist.
check here to make sure that the shape of the tissue, if you like, resembles the shape of the block.
Okay.
But then we will do a microscopic quality control as our next stage.
So this is the final stage of your quality control. You're starting to look at the sections under the microscope now.
Yes. Another important step. What Kemi's doing at the moment, she's checking the quality of the section. We checked beforehand that the numbers all match and the names all match to the card. She's done that again. It's always a different person. She's checking down the microscope for the quality, that the staining's correct, that the quality of the section that was cut earlier is correct. There are no scores in it, because a score down a microscope looks very big.
Yeah.
That it's a representative of all that section. If it's a piece of skin that is just hasn't been superficial and there's bits missing. So we're looking at the qualities. Kemi's checked that, decided it can go out to the pathologist, and has initialed the card. So
Okay,
that's now ready for the
that's the end of your process here, and you're satisfied that this is ready for diagnostic pathology.
Absolutely, yes.
Okay, it's an absolutely fascinating process. I've been really interested in seeing this. So
Well,
thank you very much,
it's been
Peter,
a
for
great pleasure
showing
to
this
show you around.
and all your staff too.
Yeah, of course. Great pleasure. Thank you.